Hi, so glad to be here. My name is Bryan Walsh. I'm the editor of a section called Future Perfect at Vox, where we cover a lot of things AI related, among other sort of future-focused technologies. So we're here to discuss how we actually implement these advances in AI in healthcare settings. I think we've had a lot of talk about some of the challenges to get this and the problems that have to be solved, I think, to make that happen. But we want to talk a little bit about how you can do it in a practical, effective, efficient, fair, and safe manner. So we're going to touch on both regulation, but I think also some institutional frameworks along the way. Turn to my panel. Just introduce yourselves first.
Sure. Hi, my name's Mike Pfeffer. I am the Chief Information Officer for Stanford Healthcare in the School of Medicine.
The fact that I'm struggling with the microphone while talking about AI is not.
It's very illustrative. That's great.
But I'm here to represent
AV.
ethics, so there you go. Danton Char. I'm one of the pediatric cardiac anesthesiologists at Lucille Packard and an ethics researcher.
I'm Nina Vasan. Oh, there we go. Okay. I'm a psychiatrist here at Stanford, and I run Stanford Brainstorm, which is Stanford's lab for mental health innovation. And basically what we do is think about what we're doing one-on-one with our patients in clinic and how do we apply that to scale. So we work with companies like Pinterest and TikTok to make them better from a mental health perspective. Because at the beginning they shared fun facts, I want to share two very quick fun facts. The first is that outside of Silicon Valley, my cool cocktail, intro or fun fact is that I have been a user of Facebook since week 2. So Mark was my college classmate, and so we all joined very, very early. So now we've used it for 20 years, and I think that's actually very much shaped my understanding of safety of tech products, and including AI. But the second is that Dr. Rodriguez was actually my preceptor in medical school. So we were at MGH using paper records and everything, and she was teaching me about the clinical exam. So it's great, 10 years later, to get to see how we've gone from pre-rounding at 4 a.m. and running around in scrubs to now having what we have today.
Thanks very much. So now we've all demonstrated our mastery of microphone technology. We're going to talk about AI for a bit. Just a reminder to the online audience, please do send in your questions, and to everyone else in the audience here to get those questions ready. So, from AI models passing medical exams to catching diseases, there is enormous AI hype in medicine. I know that as a journalist because I am on the receiving end of a lot of that hype, some of it which probably comes from this valley. How much of that is being translated into reality? Maybe you want to start.
Sure, it's a great question. I would say there's both tremendous hype and value that we're starting to see. And I must get bombarded with hundreds of emails a day of all these new AI products that I need to put into our system yesterday. And so how do you kind of make your way through all of this? I think that's one of the real challenges in when we're looking at the hype cycle of AI in healthcare. But when we think about value, we have a couple of great examples that we've looked at Stanford. I'll give you one of them. We've looked at how do we generate in-basket message responses for patients, for providers to start with. So this is one of those human-in-the-loop ideas where rather than generating a de novo response, we start with a draft response using AI. And so when we measured the success of this, we wanted to see, did it save time? And the answer was no, it actually didn't save time. And that was actually pretty disappointing. But what we did find is it actually reduced a burden. And so we're like, well, why did it do that? And so what we came to the conclusion of is it actually is reducing the cognitive load by having to generate all these messages from scratch. You get to start with a draft. The other cool thing about this is it started with 20% of the drafts being used. And in health IT, that's incredible that you get that level of use out of a brand new technology when we put it into care. So just right off the bat, I think we're going to start to see even more value from these technologies as they're implemented into healthcare. But there still is a lot of hype that we need to kind of get through.
Danton or Nina, you want to?
Yeah, please. So thank you. So with my close collaborators, Michelle Mello and Nigam Shah and Alison Callahan, we've been part of this group doing the ethical evaluation of AI technologies as they're being considered across Stanford Healthcare. And we actually just got a big grant from PCORI last month to build a scalable method to ethically evaluate healthcare applications. So I can talk a little bit about what we're seeing and some of the considerations. I think, as you can speak to, all my panelists would speak to, we are in a time of incredible labor and resource constraint in healthcare. I think at Stanford we're not as touched, but certainly going further out into the community, an entire generation of clinicians has stepped aside during the pandemic. And we've lost a lot of senior level knowledge, and there is just a tremendous amount of labor upon people. And so the things we're seeing that seem to be of benefit seem to alleviate our workforce's perception of burden and actual burden, but both the real day-to-day burdens of caring for patients, but also something that we are all culpable in, which is the redundant, burdensome, laborious, repetitive tasking, charting, and stuff that we have failed to solve with the EMR. So I think those are two areas that would be very beneficial.
Yeah, so if we think hype versus reality, I'm an optimist, so I'm gonna go on the reality side of things. I'm gonna start with a question. So, if you had a mental health struggle, let's say you're not sleeping well or you're feeling pretty hopeless, how long do you think it would take you to get help? Come to the Stanford ED or make a phone call and see an outpatient doctor, let's say. 6 months? 1 hour, yeah, okay. Anyone else? Well, the average right now in the US is not 1 hour, it's not 6 months, it's 11 years. 11 years. So when I think about something like that combined with the fact that we're in this national mental health crisis, I'm looking at this from the psychiatric perspective. I think this is fabulous. And I want to think when I think of patient stories and how patients have already gotten better from a lot of these tools, it's fantastic. I have a small private practice specifically for executives and entrepreneurs. I have a CEO who's in her 30s who basically over the last year realized she wants to explore different aspects of her sexuality, but came from a very conservative family and doesn't feel comfortable doing that outside. And so she's actually been using Replica and character AI to create an environment, right, where people are supportive of her, where she can test out how would she flirt and what would that look like for her. And so I think that's just a fantastic way. And it's not a clinical, but it really has impacted her mental health and well-being. So that's just one example of where I think there's enormous potential. And the biggest thing really is education, early intervention, people realizing that, oh, wait, something might be wrong and let me do something about it now and not wait 11 years, right? So that's part one. The second, I think, is exactly what you were talking about is on the clinician side, the burden, right? We have so much burnout and we had the privilege, we do a lot of work with the American Psychiatric Association, and they have a Shark Tank innovation competition. And the winner last year was Ambience Health, which is one of these digital scribes. And so we did a little role play. And I just have to say, I am that person who has to wait for those messages of, oh, it's been 2 weeks and you haven't turned your note in. Because in psychiatry, our notes are really long, you guys. And so just seeing the digital scribe be able to so beautifully put that note together, figure out who this patient should follow up with. It was a magical moment, I think, the first time you use Google or something, right? So I think both of those have an enormous promise.
Michael, I want to ask you something. This came up earlier at one of the panels, and I think it was that the experience a lot of doctors had with EHR was not uniformly positive, and that may inform some of their feelings about AI. I mean, I guess you mentioned with the tool you were talking about before, you had a lot of uptake right away. Is there much being done about that? Is that just something we're having to go through to get past that experience?
Yeah, it's a great question. I mean, I've spent my time in clinical informatics, almost 14 years, basically digitizing the paper world. And EHR is a byproduct of that, really. And for the first time, we're seeing technologies that required us to digitize what we had in order to really get to digital. And so AI scribes, draft in basket messages, things like this are starting to transform the way we think about electronic health records. And so some of the kind of feedback we've got when we implemented one of these solutions is really the EHR is now working for me instead of against me. And so that's amazing, right? I mean, but we couldn't have gotten there unless we actually put these things in, because we need the data to do that. The other thing I think is really interesting, when you think about AI scribes, and I think this is going to be a hugely beneficial technology that we're putting in, and the initial pilots we've seen have shown that, is really that if you think, we talk a lot about big data, but it's really the little data, the social determinants of health. It's everything that we record. And a lot of times now, clinicians write those notes later. And so they're not always accurate. And then that gets translated into model development, which then exacerbates it not being accurate. But think about this. If the AI scribes can accurately kind of scribe out what the patient is saying, and you get that accurate right at the end of the encounter, that's going to change all of the little data and help us get to a better set of big data. So I'm really excited. If we think the models now are really exciting, wait till we get better little data and better big data to develop really good models going forward.
Danton, I wonder if you talk a little bit about how you're approaching evaluation. You know, where the AI solutions you're seeing, and I think everyone else can answer this one as well, hitting those top priorities, where they're struggling to hit those top priorities, and how do you continue to evaluate? Because this is not just a one-time thing with these models; it has to be continuous.
Yeah, so it's a great question, and obviously the challenge we're struggling with. So let me parse it down in a couple of stages. Obviously, to some extent, trying to predict ethical problems before they become consequential is finding a perfect sweet spot of knowing enough about the technology that you can make some ascertainment of it, but getting to it before it actually spreads further out. There's a lot of great work by a number of scholars of values latent in technology. So somebody like Kate Shilton has done a lot of work on this. And I think we all agree the idea that to build anything, there are a number of design questions that have to be answered and that have latent in them values considerations. So one of the stages of this is trying to figure out and identify all the potential stakeholders who could be impacted by a technology and how they would answer or would want those latent values questions answered for themselves. And I think what we're seeing is where they're disagreeing, where they're colliding, that seems to be a place where either social or ethical tensions seem to emerge with a new technology. So like we were evaluating these new nursing notes, right? So nurses spend a lot of time doing end-of-shift summarization. A large language model AI tool has been being rolled out to try and identify ways it could consolidate and create a note at end of shift for nurses, right? So saving them 10% of their labor, maybe even 20% of their labor at end of shift. An area of tension that emerges, though, is what do we do with that saved 20%, right? That's a big question. If we're going to save labor, if the goal of this is to be labor expedient, obviously labor itself has real strong opinions about what happens to that time, right? So that would be a values collision that we come up. It's also obviously true that we need expert weigh-in on this, right? So it's not enough to try and identify values collisions. There are likely to be nascent or novel problems that we haven't seen yet, and that needs to be called out by the larger ethics and data science community. And so the combination of the two is what we're working on building. There's going to be a patterning component. So I think the more of this we see, the more we're going to be able to bin like with like. Like this is a predictive algorithm being applied in a pediatric population. What we've seen before are these being important ethical issues that have emerged. Or what we're seeing is this is a generative AI model being applied for whatever, but we're not there yet. And so that kind of binning is what we're working on.
Nina, what's your experience been here?
Yeah, so one, that was delightful. Thank you. I think that there are three big things that we've been focusing on: safety, efficacy, and inclusion. So, you know, we're physicians, right? And we take this oath to do no harm. I think that that needs to be the first kind of way that we're assessing any of these tools. Are they causing harm? How do we weigh that, risk-benefit ratio? And the second element is really do good, right? Like we heard about this morning, like make sure it works. And really think about that element. We have like three really simple kind of values that we think about: do what works, work together, make it last, right? Just like very simple principles, but like if those can be applied to these technologies, it goes very far. I want to share a little research actually, and Dr. Declan Grav here, Wave Declan. He's our inaugural AI fellow in our lab. And he was really interested in thinking about, okay, the next wave of all of this is agentic AI, right? It's beyond just like talking to a chatbot and really thinking in the healthcare system, we're going to want something that takes multiple steps for us and is able to do that safely, effectively. And so what Dr. Grab and we worked with a postdoc at HAI in the engineering school, Max Lamparth, and they basically came together and wanted to assess how do these LLMs really, how would they address a psychiatric emergency, right? And so we actually looked at the top 10 LLMs and ran them through all these different scenarios. And what we saw was that for suicide and self-harm, I would say they weren't bad. They knew what to look for. They were able to provide resources, and they, kind of were able to close that loop, if you will, in a good way. Now, the areas that were very concerning were psychosis and mania, where not only were they not able to really identify these harms, they actually were sycophantic at times and even, like egged the user on to believe in the delusion or do some very unsafe behavior because of what they're thinking about, right? And Dr. Grab even went a step further to figure out, okay, how do we make this better? And I think it's so, it really encapsulates this whole organization of RAISE where, on the medical side, on the tech side, we were able to bring that expertise together to figure out how do we actually change the way that these tools understand their own ability to detect something like psychosis, right? So this whole, working across campus, working across fields, I think that collaboration is something we really need to focus on. And then I'll very quickly say the final thing I was saying was inclusion. So one of the other research projects we've been looking at is just, if we now, especially looking at, GPT-4o, like if someone were to type in, what does it look like to have schizophrenia? What does it look like to have depression? What we're seeing is this horrific kind of the worst scenario, the worst like stigmatized cliche kind of depiction of what any of these diseases look like. And it's very gendered, it's very, like racist and not really thinking about a kind of positive view of how we want people to be treated. I actually think I've treated like probably 20 or 25 Google engineers with schizophrenia who are leading wonderful lives, right? So we really want to think about stigma and bias. And now that we know this is all there, how do we change the model so that they're not worsening anything like that?
That's really fascinating. I want to continue back to this, but I should open to questions in the room. Right there in the middle. Thank you.
Thanks. I guess I've been waiting for this question, opportunity to ask this question throughout the day. I don't know if it's the right place or not. But since this implementation, I'm a clinician and health IT guy who's been in the private sector and the public sector my entire career. But one thing that I haven't heard us talk a lot about is what I think is a sort of a parallel process that's happening. And that's this sort of arms race in the area of cybersecurity. And the way that healthcare data is, I think, more valuable in the criminal world than a lot of other data. And as we think about AI and all the grand opportunities and threats that we're seeing, I just wanted to hear from the panel what you're thinking about the way the criminal elements are going to get at our data through this and sort of the unique ways in which they're going to be able to use it. Because I think that's a parallel process to all the great things that we're talking about in AI. I just see this sort of a black swan event that could potentially really harm a lot of patients and our system.
Michael, do you want to tackle that first?
I guess I have to.
I guess you have to, yeah.
So I dream about cybersecurity all day long, so thank you for bringing that up. Obviously, it's a huge threat. I mean, there isn't a day that goes by that you don't hear about of something in healthcare being breached or attacked, which is awful that healthcare is in that space. Fundamentally, putting AI aside, data is an asset that is being sold on the market. But not only that, with ransomware, you're also shutting down operations, which has a huge impact on patients and communities, really. And so protecting ourselves from this is utmost priority. And AI is only going to make it easier I think, for criminal attackers to use sophisticated methods to get into health system technologies and access that data set. But implementation of AI in the health system, I don't think would really be affected by that unless we are doing, not using the software in the safe way. So typically, our philosophy on this is you really want to keep the data safe, and you don't want to have the data going to many third parties. You really want to focus on a platform approach so that data remains on the platform. Only data that's needed for the algorithm to make a decision, for example, is used and transmitted in that. And there's new modern interface technologies that you can do that with. And then as we develop models, we don't want to have data being distributed to all different places for model development, but rather development on platforms. And this is going back to the public-private partnership. That's an area that we could continue to expand as we need more and more compute to develop these things. So I think it's a really, really great point. We absolutely have to remember that cybersecurity is foremost in any technology that we implement into a health system.
Well, I would jump on and say also it challenges our ethics in an interesting way, which is that the Director of National Intelligence has released several papers about not just criminal activity, but the amassing of American and European biodata by other nation states. And I think it calls out to question both the value of biodata that you're attending to, but also the fact that we're dealing with a global AI market. And so our other nation states are viewing biodata as fundamental to privacy and security in ways that we don't here in America. And so ethics is becoming pressured in the AI space to have a local political component too. And so to some extent, like the analogy is terrible, but like in the same way that fossil fuel emitting cars had to be tuned to different markets if they're getting sold in Europe or in America, we may have to try and figure out what the core principles are that we care about and how to scrutinize our AI tools, particularly if they're coming from other locations to us, or if our data is being shared across other locations. I'm sorry to jump in on you.
That's great. Thank you.
Great. I'm going to take a question from online. When you're thinking about AI implementation, how much should clinician experience factor into the evaluation process? I assume that means your experience more broadly as a clinician. But Nina, maybe you want to start?
Yeah, I would say absolutely. I think exactly what we've heard today from so many people is just the importance of clinicians collaborating when all of this is made. And if we think historically, right, the tools that didn't work, that had so much hype, that was a big factor, right? So I think it's our part of our professional social responsibility as clinicians to be proactive and look at these different tools, weigh in on our clinical perspective, because it's going to affect our patients no matter what, and we need to make sure that it's safe and effective.
Good.
Yeah, it's a great question, and Nina, completely agree. The workflow part of implementation is probably way more important than the model. There's so many examples of this, but if we take sepsis detection, there's probably hundreds of papers of it works, it doesn't work, it works, it doesn't work. And it's not the model that's the problem, it's the workflow. And so if you think about this, absolutely the clinicians need to be involved in everything we implement in AI, because it's the workflows that matter. And if we don't get the workflows right, and we don't integrate the prediction or the summarization or whatever the model is going to produce into the workflows that clinicians are currently using, it won't work. So I think there's a real opportunity to make sure we continue to do this. What's amazing is the field of clinical informatics didn't really exist that long ago. And now we have all these clinician informaticists, and it's super exciting. So I feel very optimistic that we're going to get this right. If you asked me 10 years ago, are we going to get this right? I probably would have said no. But I think we're poised to do this well. But workflow, I can't emphasize that enough. It's not the model that we have to worry about. It's the workflow.
I'll add in really quickly that I think that in addition to looking at the clinical space and anything that's going to be used from a clinical perspective, we also need to look at the non-clinical space. And this is having worked in social media safety, where things like realizing, being on Instagram, being on TikTok worsens eating disorders, or it makes people more depressed or anxious. So, and that's not a clinical thing, right? But now we're seeing the sequela of that in clinic. So I think we need to really be proactive and responsible as all these tools are being created. And to your point, all AI, right? Because there are health effects for a general user, and and certainly someone who's struggling with any aspect of their health. So just we have to be out there.
Did you anything or?
I mean,
Yeah.
yes.
All right. Just what actually, as when you asked one question, you mentioned social media. I know that this has been a big part of your work. You're also a second week Facebook joiner. What can we learn from our experience with social media in terms of adapting to AI? I guess both in terms of the patients, but also the clinicians, really what we should look out for there.
First of all, you set me up beautifully. Thank you. And whenever I'm pitching to donors, I just want to ask Bryan for some help. I think you nailed it, which is that, if we look at the past 20 years of social media, we see a lot of, we see like really well-intentioned people who were using technology to try to make the world better. And they did in so many ways, right? Like there's so many ways that we're all better off, that we're healthier, that we're happier, that we're more connected. And incredible harm was done. And really, if we think about something like Facebook, it took probably about 10 years to even realize the impact of these harms, and literally 20 years for us to actually start writing legislation. That's unacceptable. We absolutely cannot do that with AI. And I think we have a lot to learn from social media to be able to say, oh, wait a second, we didn't realize these harms were going to be there. Now that we know that happened with social media, let's apply that to AI and be proactive about understanding if someone's using ChatGPT for 3 hours a day, what are the other things that they're dealing with that we might not realize, just like we didn't realize with social media. And then the final thing is, like you said this beautifully, we have to be proactive, right? We have to recognize there is harm there. Let's work together with researchers, and especially thinking about kids and teens. Like more than 50% of kids have used some Gen AI product in the last year. That's enormous. And so how do we keep everyone safe? And policy, I think, that's one of the things we're trying to talk about is we have to be proactive about writing this policy. Unfortunately, policymakers are not necessarily domain experts, right? They don't know as much about AI. They don't know the nitty-gritty of healthcare. And so we need to bring that to them, work together with them so that we have something. And the very last thing I'll say is we're actually working with Common Sense Media on this right now on the kind of first, user-centric AI policy in the state of California. And I think that's exactly what we just need to do is put it out there and make it clear that this is something for health, this is something for well-being and for the safety of our country.
That connects really well to one more question I want to ask before I go back to the audience for towards the end here. I think with what we're seeing with the push for AI regulation is in part related to the feeling that we didn't do it fast enough with social media. But at the same time, even with regulation has an important role to play, there are challenges and trade-offs. Everything comes with trade-offs, including regulation, perhaps most of all. So what trade-offs do policymakers face as they weigh these potential guardrails, both to put the right ones in place, but obviously not to sidetrack progress along the way? Anyone go?
I mean, certainly that's the chief issue, right? So in pediatrics, that's even more heightened, right? So we're already concerned with AI about it's a very fragile population. We want to protect their safety, and yet in doing so too aggressively, we're going to deter innovation in that space, right? Developers are going to say, it's already expensive to deal with kids. It's already a very small market. We're just going to do what we did with drugs and step back and let it sort of, be non-licensed use. How to find that sweet spot is very challenging. I think we would encourage not too aggressive regulation right now. I think the ethics community has multiple examples when it looks within itself to say, look, we've had several times where, with neonatal blood spots or with recent religiously motivated oversight of NIH fetal stem cell regulation, where the ethics review itself was overly constraining of innovation and development in particular ways. And so I think we need more data before we can come up with sweeping regulation.
Michael?
Yeah, I completely agree. I mean, as Ken mentioned before, healthcare costs are unsustainable, and we make a lot of errors every single day. So we have to figure out how to do this right, and we can't have regulation prevent us from learning how to do this right. So I don't have a great answer on how to solve the problem, but we want to find that sweet spot. Otherwise, we're going to be stopped in being able to really understand how to do this well and learn from it.
But I mean, what I would say on the dovetail of that is that what we've seen, at least working at Stanford and across Chai, and what I'm hopeful for within healthcare is that people do want to do the right things. Or apropos of your social media question, the problem is figuring out what is the right thing, right? So I think the guidance that we need to provide now is what is the right thing we should be doing? What is it we should be looking at? And from that, we can get regulation.
I think this afternoon we should have that exact discussion.
I think we have time for one more question for the audience, right? Go ahead. Thank you.
Thank you all. Ala Yusuf, Stanford Amy, postdoctoral scholar. I guess one question, maybe to direct it to you, Nina, is no one can deny the impact and clinical effectiveness of digital health for youth in terms of how it really improved mental health access. The number one concern is as more of the conversational AI explosion is going on, as people seek mental health from these health apps, how do we understand the clinical effectiveness as well as the harm that unlikely for us to see? Like, I think, as Michael said, we worry about the errors we see, but there's errors that we won't see. And so what is going to be the circular loop mechanism for physicians and mental health experts to say, you know, this is harm, this is ethical errors?
You nailed it. That's, I think, exactly what we need to be thinking about. And really, it requires good research. We need good research studies that are able to study this. And unfortunately, a lot of the social media research is pretty bad. You know, it's not controlled well. And there are obvious reasons why, right? But I think that being able to kind of work together with the research community and clinical community, as well as then product development, and understand, you know, the companies are certainly looking at this from the product perspective and what gets people to stay on longer, right? And what makes them engage. But we need to think from the health and safety perspective, and do just as they do all the market research, we need to do, I think, more clinical studies so that we can identify this early, and more than just, or in addition to what harm is caused, for whom, right? We need to really nail down, for example, now we're realizing, oh, this is like, social media was much worse for teenage girls than anyone else, right? And so how do we actually pinpoint that so that we can then start to make strategies to make people better and let them use these products in a safe and effective way?
We have time for one more question if it's fairly brief. Right?
So maybe going back, Antonio Moore from Stanford. Just going back a little bit about regulation, right, and how this is going to play out. We have institutional review boards at the core of FDA approvals. And in institutional review boards, there are people that understand the clinical research and what goes into the decision-making process. How are we going to do this if you don't have the mass of people that actually understand these and make decisions for implementation and even for research? So any thoughts on where we're going to get the critical mass to even evaluate these things?
It's a very good point. Who has an answer there?
Well, I have no idea, but let's take it, even further is when we implement these models and, we'll start to have models and models and models. How do we then monitor them going forward? So it's how do we determine how to regulate these things up front, and what should be then moved into production, and then how do you monitor all of them, and where are all these people going to come from to do it? And Nigam, I think, rightly talked about, we need to get really good at software, because software is going to help us do all of these things that there's no way we could scale. If you think about it, every health system having to monitor hundreds of models in their environment to make sure they're not skewing or causing harm, it's impossible. So we're going to need to solve this with software so we can make sure that the models are performing the way we expect them to and not causing harm.
Certainly, also it's a fair question as to what extent IRBs are going to be the right mechanism for it, because clearly IRBs are best at regulatory compliance and sort of adherence to ethical norms, and whether we're there yet for AI, or whether already overburdened IRB systems could handle the explosion of AI-based research is a fair question.
Hey, one last word.
I'll do one last thing, and I'm actually going to throw back to the previous question around, how are we even going to understand what people are dealing with? And so I'm going to put an ask out there to the in-person audience and especially the Zoom audience. We're trying to collect patient stories to really understand, let's see what 100 patients can tell us about how they're using Gen AI, how it impacted them clinically. So if you have any patient stories about your patients using Gen AI and what ended up happening, please do reach out. We'd love to share these stories. Our email address is brainstormlab@stanford.edu. And I am would love to, come back next year and share what we collectively were able to understand about this.
Well, thank you to all our panelists. Please give them a hand.
Thank you, Bryan.